Morning, afternoon, good evening, global population. How are you all doing? Sam Fisher here. Well, how many idiots does it take to change a light bulb? Well, don't ask Sage. You won't get any straight answers.
The Government Chief Scientific Advisor, and I'm here with Chris Whitty, the Chief Medical Officer, and we wanted to give you an update on where we see the epidemic at the moment, some of the knowns and some of the uncertainties. Let me just start by reminding you that this disease spreads by droplets, by surface contact, and by aerosols, hence the hands, face, space, but also to remind you that the way that we reduce the spread is by limiting our number of contacts, by reducing contacts in environments where spread is more likely. Those are crowded environments, indoor environments, poor ventilation, and making sure that we reduce the probability of coming into contact with anyone who is infectious, and that's the importance of self-isolation, keeping out of circulation if you have or may have the virus. May I have the first slide, please? I want to start by talking about the rise in cases elsewhere and what we can learn. We've seen increase in cases across Europe, and here I've taken examples of Spain and France. We've seen an increase in the numbers of cases. It started with younger people in their 20s and spread gradually to older ages as well. That increase in case number has translated into an increase in hospitalizations.
Acabamos de escuchar ingresadas en la UCI. Nos atiende ya el doctor Luis de Benito. Hola, ¿qué tal, doctor?
Buenos días.
Doctor, usted conoce muy bien cuál es la situación. Ha estado desde el principio, desde que comenzó la pandemia, trabajando con pacientes con coronavirus. Actualmente está en el Hospital del Escorial, aquí en Madrid. ¿Exactamente cuál es? La situación es preocupante, y ya podemos hablar de total saturación. Hay hospitales, estamos escuchando, que se están poniendo las pilas con más plantas, pero ¿podemos definirlo ya?
Pues no, vamos a ver, es que yo no sé exactamente a qué hospitales preguntáis, porque vamos, es cierto que se está notando un repunte en el número de ingresados, pero vamos, te voy a decir, la semana pasada en el Hospital del Escorial no había nadie, ayer había 3. Tres de más de 200, unas 100 y pico camas, ¿no? Es decir, que no me parece un porcentaje de saturación. Y quizá el hospital que está al dicho como que es el que está más saturado, que es el 12 de octubre.
El 12 de octubre era el que estaba quitando, les ha quitado ya las operaciones programadas y que además también se están desplazando a los pacientes en consultas externas, las que consideran de menor importancia.
Sí, pues bueno, ayer los datos que daba la Comunidad de Madrid eran 75 ingresados. 75 ingresados en un hospital de 1.300 camas.
Eso es, y 540 contagiados.
Pero esos 540 contagiados son PCRs positivas. Es que ahí es donde están los datos equivocados, no confusos. Es decir, en los centros de salud se dedican a hacer pruebas de PCR y hay mucha gente que lo tiene. De hecho, están ingresando en los hospitales, por ejemplo, tráficos, que les hacen una PCR positiva y entonces lo contabilizan como COVID, cuando es un tráfico. Lo que pasa es que, bueno, hay una confusión en esto de que están aumentando los números de COVID. Pues no es verdad. Están aumentando, pero no los pacientes con patología COVID. Patología COVID es la que vimos en primavera, cuando teníamos los hospitales saturados. Ahora está habiendo, sí, un repunte de casos, pero simplemente porque estamos haciendo muchas más PCRs. Y hacer PCR no quiere decir que estén contagiados, que estén enfermos necesariamente.
Ahí, por ejemplo, en su hospital, exactamente, ¿cómo están haciendo ustedes? ¿Hay, sí, una forma de ponerse a punto de cara a septiembre, octubre? ¿Está todo el personal sanitario ya de regreso?
Como están de vacaciones, como las autoridades, están de vacaciones como el gobierno, es que alarma no hay. Hay una situación de alerta, pero no es alarma.
¿Y reemplazo para doctores, para médicos, para enfermeros? ¿Hay?
Eso no tengo mucha idea del plan que tienen previsto. Es como todo, la previsión que se hace de suspender consultas o suspender quirófanos, pues se hace en base a que no hay sangre en el banco o no hay personal. Lo de los pacientes todavía estamos por verlos, porque realmente verlos no los hemos visto, por lo menos como en primavera.
Bueno, repito, 540 ingresados, contagiados y 70 en la UCI, para dejar las cifras claras. Hay un libro que usted conoce muy bien, ¿verdad que sí? Se titula Coronavirus tras la vacuna. Entiendo que estará atento a la información que está saliendo. Vacunas, Rusia, Alemania. Ayer saltaban las alarmas. Hoy parece que no la va a tener a punto para otoño. La de Pfizer, que parece que tiene un poquito más de eficacia. ¿Cómo lo ve?
Bueno, sí es cierto que es muy comercial hablar de una vacuna, sobre todo cuando previamente se ha metido miedo y se ha hecho creer que hace falta, porque claro, hay que colocarla. La cuestión es si realmente es necesaria, primero si es segura, segundo si es eficaz y por supuesto el principal si es necesaria o no, porque si resulta que es cierto que están contagiándose tanta gente, digo yo, ¿para qué va a hacer falta una vacuna si ya todo el mundo la ha pasado? Se desmonta, ¿no? Un poquito la necesidad de una vacuna.
Sí.
Lo que hay que vacunarse contra el miedo, porque eso sí, la alarma social que se está generando con esto, a los médicos desde luego nos deja perplejos.
Nos deja entonces un mensaje de tranquilidad, pero yo insisto, porque llevamos una media de más de 1000 positivos al día en España.
Vale. Y
Entonces...
si miras, por ejemplo, el Helicobacter pylori lo tiene el 50% de la población española y además es un carcinógeno tipo 1, o sea, dicho por la OMS, o sea que la mitad de la población española tiene riesgo de tener cáncer de gástrico. Fíjate qué grave. ¿Es motivo de alarma? ¿Están en los periódicos? Es que no es motivo de alarma.
Respecto a la gente que está ahora de vacaciones, ya que estábamos citando, bueno, son muchos. Madrid, por ejemplo, está vacío, podemos decir. Las grandes ciudades sí que lo estamos notando, que la gente se ha ido de vacaciones. Ahora nos espera un regreso, septiembre. ¿Algún augurio? ¿Usted tiene alguna previsión de lo que pueda pasar o seguiremos siendo tan optimistas?
No, nosotros vamos, los médicos, por lo menos con los que yo trato, que son alrededor de 300 enfermeros y médicos repartidos por toda España, lo que tienen muy claro es que hay una maniobra para confinar a la gente ahora en septiembre, haciendo ver que hemos sido muy responsables durante el verano, porque estratégicamente es interesante y además nos viene muy bien a los médicos que no vayan los pacientes a los centros de salud, que están cerrados y esas cosas, ¿no? O sea, que estratégicamente funciona bien, pero desde luego desde el punto de vista médico pensamos que hay poca chicha. Desde luego no esperamos un repunte como nos pasó. En primavera sí que era necesario que los medios de comunicación hubieran hablado de saturación, desborde, porque cuando sacábamos a los hospitales a los pacientes fuera de los hospitales, los llevamos a los hoteles, porque ya no teníamos camas para albergarlos. En primavera sí, ahora... Antes no había una pandemia y no hablabais de ella, y ahora que no la hay, habláis de ella a todas horas. La verdad es que no lo entiendo, pero bueno, se trata de dar la noticia.
Doctor, creo que nos han encendido un poquito las...
Se nos ha ido un poquito la pinza,
las alarmas. Bueno, aquí está generando sus palabras cierta crítica en el plató. Le contesta, va a hablar con usted Francisco Javier Barroso, periodista que está aquí en el plató.
Mire, doctor, no sé o si le he entendido bien o a lo mejor nos ha explicado usted bien. Vamos a dejarle una puerta abierta, porque decir que no hemos hablado de la pandemia durante marzo, abril, mayo, junio y hasta hoy es llamarnos tontos al resto de la población. Disculpe que sea tan sincero.
¿Cómo que tontos?
Es que no hemos
Perdón, es que no hemos hablado de otra cosa. Ha sido monográficos de 24 horas en todos los medios de comunicación.
El tratamiento de la noticia no ha sido el mismo.
Hombre, por supuesto que cada uno ha hecho el tratamiento que ha creído conveniente, pero decir que no se ha tratado la pandemia, como acaba de decir usted, ¿usted en qué mundo ha vivido? Discúlpeme.
Dentro de los hospitales, amigo. ¿Usted dónde ha vivido? ¿Detrás de una redacción?
No, perdone, yo he estado en la calle, he visto muertos y he visto a gente enferma. Y le vuelvo a decir lo mismo, se ha tratado la pandemia.
¿Ha firmado usted certificados de función?
No, mire, por desgracia no tengo esa suerte.
Bueno, yo creo que vamos a dejarlo aquí. Cada cual ha podido exponer su punto de vista. Luis, doctor, le agradezco que haya estado con nosotros, que nos haya atendido. Gracias.
But not unexpectedly, deaths are also increasing. So there's a simple message from this slide, which is that as the disease spreads, as it spreads across age groups, we expect to see increase in hospitalizations, and unfortunately, those increase in hospitalizations will lead to an increase in deaths. The virus has genetically moved a bit, but it has not changed in terms of its propensity and its ability to cause disease and to cause death, even though, of course, most of the disease deaths occur in the older population. So where are we here? Next slide, please. These are data from testing, and I'll come back to that point in a minute, and they're data for England, but the picture is fairly similar across the UK, and Chris Whitty will say more about that. What we see from July, as we look at the increase in cases per 100,000 of population, an increase which has occurred over August and has increased into September. This is by different age groups, and the top line, the blue line, is amongst the 20 to 29-year-olds. But what you can see is there's been an increase in cases across all age groups. The lowest increase has been in children and in the population aged 70 to 79, but in every age group we've seen an increase. Could that increase be due to increased testing? The answer is no. We see an increase in positivity of the test done, so we see the proportion of people testing positive has increased even if testing stays flat. And if we look at other sources of data, such as, for example, the ONS study, which takes a sample of people across the population and looks at it, or studies like the REACT study, we see a similar increase. In the ONS study, it's now estimated that roughly 70,000 people in the UK have COVID infection, and that about 6,000 people per day are getting the infection. So we are in a situation where numbers are clearly increasing. They're increasing across all age groups. It's a little bit different in different areas in terms of geographies, and Chris will speak to that. And this increase in numbers is also translating into an increase in hospitalisation, which Chris will say more about. So there's no doubt we're in a situation where the numbers are increasing. What I'd like to do is just remind you how quickly this can move. So the next slide is not a prediction, but it is a way of thinking about how quickly this can change. So this is the UK reported cases per day against time. And you can see running along the bottom there, the number of cases over June, July, and August, up to roughly 3,000 cases per day or so in September, middle of September. At the moment, we think that the epidemic is doubling roughly every 7 days. It could be a little bit longer, maybe a little bit shorter, but let's say roughly every 7 days. If, and that's quite a big if, but if that continues unabated, and this grows doubling every 7 days, then what you see, of course, let's say there were 5,000 today, it would be 10,000 next week, 20,000 the week after, 40,000 the week after. And you can see that by mid-October, if that continued, you would end up with something like 50,000 cases in the middle of October per day. 50,000 cases per day would be expected to lead a month later, so the middle of November, say, to 200 plus deaths per day. So this graph, which is not a prediction, is simply showing you how quickly this can move if the doubling time stays at 7 days. And of course, the challenge, therefore, is to make sure that the doubling time does not stay at 7 days. There are already things in place which are expected to slow that, and to make sure that we do not enter into this exponential growth and end up with the problems that you would predict as a result of that. That requires speed, it requires action, and it requires enough in order to be able to bring that down. One final word on this section. So as we see it, cases are increasing, hospitalizations are following, deaths unfortunately will follow that, and there is the potential for this to move very fast. A word on immunity. Next slide, please. When people have an infection, the vast majority of people get an antibody response. And we know that some of those antibodies are so-called neutralizing antibodies. They do indeed protect against the virus. We also know that they fade over time, And there are cases of people becoming reinfected. So this is not an absolute protection, and it will potentially decrease over time. What we see is that something under 8% of the population have been infected as we measure the antibodies. So about 8%, so 3 million or so people may have been infected and have antibodies. It means that the vast majority of us are not protected in any way and are susceptible to this disease. There may be other forms of protection that increase that number a little bit, other parts of the immune system, but it does mean that the vast majority of the population remains susceptible, and therefore you'd expect spread throughout them. The number of people with antibodies is a little higher in the cities, and it may be as high as 17% or so in London. That may confer a little slowing of spread, but not much more than that. At that point, I'll pass over to Chris to take you through some of the other features of the epidemic. Chris.
Thanks, Patrick. Next slide, please. What we have here are two maps. They're from England, but there would be similar ones from Scotland, Wales, or Northern Ireland. And what we have on the left here is a map where the darker colours are the rate of transmission. And on the right, what we have is a map where orange or yellow or brown represent an increasing rate of transmission. The darker that colour, the greater the rate of increase. And green or blue represent a stable or falling situation. And what you can see on the left side is that at the moment, the very high rates of transmission in the UK are highly concentrated in particular areas, but there are significant rates of transmission in many parts of the UK with the darker colours. But what we've seen is a progression where, after the remarkable efforts which got the rates right down across the country, firstly, we saw very small outbreaks, might be associated with the workplace or another environment. Then we've seen more localised outbreaks, which have got larger over time, particularly in the cities. And now what we're seeing is a rate of increase across the great majority of the country. It's going at different rates, but it is now increasing. And what we found is that as we go through in time, anywhere which was falling is now moving over to beginning to rise, and then the rate of rise continues in an upward direction. So this is not someone else's problem, this is all of our problem. Next slide, please. This graph is a simple one. It simply shows the number of inpatient cases in England over the period from the 1st of August. And until that point in time, there had been a steady fall over a long period of time, right back from early April. And it then stabilised for a period and flattened out. But over the period since the 1st of September, you can see a steady, sustained rise in numbers with a doubling time, as with the cases, of probably 7 or 8 days. Now, what that tells us is that if this carried on unabated, these numbers are relatively small. We're talking about around 200 at the moment. But if we continued along the path that Patrick laid out, the number of deaths directly from COVID, I'll come back to indirect deaths, will continue to rise, potentially on an exponential curve. That means doubling and doubling and doubling again. And you can quickly move from really quite small numbers to really very large numbers because of that exponential process. So we have, in a bad sense, literally turned a corner, although only relatively recently. And I think everybody will realise that at this point, the seasons are against us. We're now going into the seasons, late autumn and winter, which benefit respiratory viruses, and it is very likely they will benefit COVID as they do, for example, flu. So we should see this as a 6-month problem that we have to deal with collectively. It's not indefinite, and as I come on to, science will in due course ride to our rescue. But in this period of the next 6 months, I think we have to realise that we have to take this collectively very seriously. A lot of people have said maybe this is a milder virus than it was in April. I'm afraid, although that would be great if that were true, we see no evidence that is the case. At the moment, because the cases started to rise most in the lowest age bands, in young adults, not in children. Children, the rates have really not increased, as the data Patrick showed young children, but in young adults, these are the group who are least likely to end up in hospital. And a point we made right from the beginning is that for many people, this remains a mild infection. But as you move up the ages, if you move into people who are more vulnerable, then the mortality rates, if people get this, rise to quite significant rates. And what we've seen in other countries and are now clearly seeing here is that they're not staying just in the younger age groups, they're moving up the age bands, and the mortality rates will be similar to, slightly lower than they were previously, but they will be similar to what we saw previously. And these are significantly greater, for example, than ordinary seasonal flu. So seasonal flu normally in the UK would on average a year kill around 7,000 people a year, tragically, and in a bad flu year, as there was, for example, about 3 years ago, it might kill upward of 20,000 a year. This virus is more virulent than flu. So the numbers people talk about are not unreasonable numbers for us to be thinking about. Treatment is better. There's no doubt about that. Doctors, nurses have learned to treat this much more effectively, and we have new drugs such as dexamethasone. These will reduce the mortality rate, but they will definitely not eliminate or take it right down to trivial levels. Two other broad points I wanted to make. The first one is that there are, as we've said from the beginning, and it really does need to be repeated, 4 ways in which this virus is going to have a very potential significant effect on the population's health if we let it go out of control. The first, the easiest to identify, is direct COVID deaths, people who get the virus and die of the virus. The second would be if the NHS emergency services were overwhelmed by a huge spike, and that is what the extraordinary efforts of the population allowed to prevent happening in the first wave we met. The third, however, is very important, and I think its importance should not be understated, which is if the NHS is having to spend a large proportion of its effort in trying to treat COVID cases, because the numbers have gone up to very high levels, and trying to put in place large numbers of systems to try and reduce the risk of transmission in hospitals, it will lead to a reduction in treatment for other areas, in early diagnosis of disease, and in prevention programs. And so there is an indirect effect on deaths and on illness from this impact on the NHS if we allow the numbers to rise too fast. But on the other side, we also know that some of the things we've had to do are going to cause significant problems in the economy, big social impacts on mental health, and therefore ministers making decisions and all of society have to walk this very difficult balance. If we do too little, this virus will go out of control and we will get significant numbers of increased direct and indirect deaths. But if we go too far the other way, then we can cause damage to the economy, which can feed through to unemployment, to poverty, to deprivation, all of which have long-term health effects. So we need always to keep these two sides in mind. My final point is that if I increase my risk, a lot of people say, well, can't people just be allowed to take their own risk? The problem with a pandemic or an epidemic infection like this is if I as an individual increase my risk, I increase the risk to everyone around me and then everyone who's a contact to theirs. And sooner or later, the chain will meet people who are vulnerable or elderly or have a long-term problem from COVID. So you cannot, in an epidemic, just take your own risk. Unfortunately, you're taking a risk on behalf of everybody else. It's important that we see this as something we have to do collectively. And there are broadly 4 things we can do over the next period to get on top of this. The first of which is reducing our individual risk. And this is around the things that we all know about: hands, face, space, washing hands, using masks, particularly in environments which are enclosed, in public transport and so on, and also, in particular, having space between people whenever we can achieve it, especially when indoors. The second group of things are things we can do to isolate the virus. So if people have symptoms, they must self-isolate, and we must find their contacts so that they can isolate, and in people who've travelled from high-risk areas, they also should isolate. And this means that they are taking, on behalf of society, a big step forward to keep the virus out of circulation whilst they are still infectious. This is an absolutely critical part of the response. The third one, and in many ways the most difficult, is that we have to break unnecessary links between households, because that is the way in which this virus is transmitted. And this means reducing social contacts, whether they are at work, and this is where we have enormous gratitude to all the businesses, for example, who worked so hard to make their environments COVID secure to reduce the risk, and also in social environments. And we have to try and do this in the least damaging way. But we all know we cannot do this without some significant downsides. And this is a balance of risk between, if we don't do enough, the virus will take off. And at the moment, that is the path that we are clearly on. And if we do not change course, then we're going to find ourselves in a very difficult problem, as Patrick has laid out. The final thing we can do is the science, is investing in drugs, vaccines, diagnostics, and Patrick is going to take us through, as the final section, where we've got to with the most exciting of these, which is vaccines.
Thank you very much. As Chris has said, we will be living with this virus. This is now circulating amongst the population worldwide. It will continue to do so. We will be learning how to live with it. One important part of that is vaccines. I'm pleased to say that there is good progress that's been made. Many vaccines now have shown they generate an immune response of a type that ought to be protective, and several vaccines are in very late stage clinical testing, aiming to show that they are both effective and safe. The UK, through the Vaccines Task Force, has got access to a number of these, as illustrated on this slide, with a range of different vaccine technologies from a number of different companies. The UK, therefore, has put itself in a good position in terms of vaccine supply and the possibility that one of these will work. We don't yet know that they will work, but there is increasing evidence that it's pointed in the right direction, and it's possible that some vaccine could be available before the end of the year in small amounts for certain groups. Much more likely that we'll see vaccines becoming available over the first half of next year. Again, not certain, but pointed in the right direction, which then, of course, gives the possibility of a different approach to this virus. But in the meantime, we've got to get on control of this in the way that Chris has described, in order to make sure that we can live with it in a way that's sustainable and protects health and society overall. Thank you very much.
So, 2 days ago, we had a press conference from our de facto leaders, our secret government, that being Sage. It was basically dimmer, and later on we had a speech from Broken Lightbulb. During that speech, they basically insinuated they were going to do a second lockdown. The reason being is because more cases more cases isn't because of more testing being done. What? Seriously, this is their thinking. More testing doesn't equal more cases. That was the first lie. The second lie was about an uptick in deaths and hospitalisations in Spain and in France. Well, as far as I'm aware, Spanish frontline doctors and French frontline doctors basically debunked that the day before. They went on record saying whatever the French government is telling you and whatever the Spanish government is telling you is a lot of bollocks. In a nutshell. There is no uptick in deaths. There is no uptick in hospitalisations. It's all lies, which is what they said. This is meant to be two of the hardest hit nations there is in the whole of Europe. France and Spain, along with Italy and us. The fuck's going on there, eh? And all the while in the background you can hear someone going, Sweden, don't mention Sweden, don't mention Sweden, keep your fucking mouth shut, don't mention Sweden. So, you know what? Surprise, surprise, didn't mention Sweden. And then we had Broken Light Bulb coming on later on. If anyone's wondering who Broken Light Bulb is, that's Boris. May as well be the Broken Light Bulb. He came on later on to stress the point of the de facto government, the lead spokesman. Someone made a comment on the video saying, "Oh, they look very dictatorial." There's a reason for that, because they are. Dictators, our fascist dictators. He's doing this in lead up to the whole Corona Act being renewed on October 1st. That's the cut-off date, that's the 6-month cut-off date. And he's doing this to ramp up fear. If any of you have any sense, you'll start writing to your politicians and saying, do not renew that act. Bury these idiots. Our MPs need to stand together. We need to stand together. Like I've said, forget your differences. Religion, race, whatever it is. We're all one human race and we need to come together. Right now, Britain's at stake. If we can stop them, it'll start a domino effect. If we fail, we're all screwed. Trump's let his side down in the US. He signed them in for another 6 months. We need to get that act not signed in, whatever the cost. Anyway, like, subscribe.